The next agent for bipolar disorder that we're going to talk about is called carbamazepine. In terms of its mechanism of action, again, for its treatment of bipolar disorder, it does have a complex mechanism of action, but it's not completely understood how it works for bipolar disorder. Carbamazepine, just like valproic acid, is also an antiepileptic drug. So how we see that it works is it blocks voltage-gated sensitive sodium channels. It stimulates the release of antidiuretic hormone and decreases serum concentration of sodium. It blocks calcium influx through the NMDA glutamate receptor and decreases calcium serum concentrations. Again, these kind of decreasing the excitatory activity in the brain. We also see that it might have anti-kindling properties, preventing future episodes of either mania or depression from occurring with minimal stress, and that these properties may decrease rapid cycling as well as mixed states of bipolar disorder. Of note, carbamazepine is structurally similar to our tricyclic antidepressants. Regarding indication and formulations, we do have an FDA-approved indication for the management of bipolar disorder. It's actually with a specific brand name product only. So really, for FDA-approved indications for the agents that we use in bipolar disorder, I'm less concerned because a lot of these products we use technically off-label. The other things that we use carbamazepine for is, as I said, epilepsy, as well as trigeminal neuralgia. So expect to see more about carbamazepine coming back in neurology. Formulations, we have an immediate release tablet, an ER capsule, an ER tablet, a suspension, as well as a chewable tablet. Like valproic acid as well as lithium, when we look at carbamazepine, it is also pregnancy category D. The concern here is that it may be associated with teratogenic effects such as spina bifida, craniofacial defects, cardiovascular malformations, and possible developmental delays. Carbamazepine is also excreted in breast milk. So again, category D means that there is risk, however, benefits may still outweigh the risks. Pharmacokinetics. So pharmacokinetics with carbamazepine is actually really important because it's actually pretty unique. So absorption, it does have a slow and variable absorption, which does get delayed by food. It's about 85% bioavailable. Carbamazepine, just like valproic acid, is rather highly protein bound. Now, here's my blob. So metabolism is via CYP450-3A4. Carbamazepine is both a substrate and an inducer at CYP3A4. It is also an autoinducer, meaning that carbamazepine actually induces its own metabolism. Again, carbamazepine is also an autoinducer such that it also induces its own metabolism. So lots of drug-drug interactions. Half-life differs because of differences in autoinduction. So initially, the half-life of carbamazepine is anywhere from about a day to 65 hours. And then once it's started to induce its own metabolism, the half-life actually goes down to about 12 to 17 hours. So autoinduction begins after 3 to 5 days of therapy initiation and isn't complete until after about 2 to 3 weeks upon dose stability. So we start to see autoinduction 3 to 5 days after therapy is started, and then autoinduction will still continue to occur and not reach the maximal effects until about 2 to 3 weeks. So the key here is to know, basically carbamazepine is chewing itself up, so we typically will need higher doses than the initial dose of carbamazepine for chronic use. So again, for dosing, in general, we're going to start with 200 milligrams twice a day, increasing in 200 milligram increments per day every 3 to 4 days. And then chronically, we tend to need, again, higher doses than the starting dose, So target is going to be between 600 to 1200 milligrams per day, with our maximum dose being 1600 milligrams per day. We also have carbamazepine serum levels that we can check. Again, similar to valproic acid, the carbamazepine serum levels were developed as the therapeutic range for epilepsy. They weren't developed for the therapeutic range for bipolar disorder. So we do want to check levels to make sure that patients are within a safe zone. However, the level does not necessarily indicate that this is the level that they will be treated for bipolar disorder. What we do see is that levels greater than 12 micrograms per ml have been associated with toxicity. So levels greater than 12, we might see ataxia and nystagmus. Levels greater than 40, we may actually see coma and seizures. So the level we're looking for is between 4 to 12 micrograms per ml. Now, in terms of monitoring, we will monitor to make sure that patients are within that safety range, also to see what level they're at that led to mood stability so that we can make sure that they stay within that level. We can also check levels to see, is the patient are they actually taking the carbamazepine? And then also if there's any new drug interactions. So we have 2 black box warnings here for carbamazepine. So there's my nice little blob. So the one is a serious dermatologic reaction, so Stevens-Johnson syndrome and toxic epidermis necrosis. And this is in the presence of HLA-B 1502. So we actually recommend genetic testing for the HLA-B 1502 allele, specifically in Asian patients. This is a genetically susceptible population to have these severe and life-threatening dermatologic reactions. The most genetically susceptible is the Han Chinese. The other black box warning is for myelosuppression and hematologic toxicities. So carbamazepine can lead to agranulocytosis as well as aplastic anemia. So again, these are rare, but again, we get the black box warnings due to the severity of the effects. Carbamazepine, again, not an all-inclusive list when we have side effects. Similar to valproic acid, we have dizziness, somnolence, sedation. Again, our anti-epileptic drugs, when they're working to decrease excitatory activity in the brain. So really, again, the somnolence, sedation, dizziness are very common side effects. We also have ataxia and slurred speech, headache, hyponatremia, because remember it does have a little bit of an activity on antidiuretic hormone. We can also see a transient LFT increase and then the concern for severe rash. Okay, so how do we monitor carbamazepine? So we will want to check the serum level. Again, to establish at least if a patient has responded, to establish whatever level has led to that response. We'll check the CBC because, again, the myelosuppression. So we'll first start by checking every 2 weeks during the first 2 months of therapy and then extend to every 3 months. Similarly, we'll want to do LFTs every 2 weeks during the first 2 months of treatment, then every 3 months. Given the pregnancy concerns, we will want to do a pregnancy test both at baseline and then as indicated. Now, when it comes to the carbamazepine level, think back, how long did I say until autoinduction ends up being completed? About 2 to 3 weeks. So if you check the level, 1 week upon starting carbamazepine, that level is likely going to be falsely elevated because autoinduction has not completed. So you're going to want to wait to get your level once autoinduction has completed. You can check a level earlier on, but do that primarily for toxicity. And again, the autoinduction is going to make the level decrease over time. Now, as I mentioned, carbamazepine is a potent inducer of CYP3A4 as well as an autoinducer of its own metabolism. So we do see a lot of drug interactions. So some anticonvulsants. So phenytoin and the barbiturates are also CYP3A4 inducers, which we'll talk a little bit more about next block. But together with carbamazepine, these agents all together are going to decrease each other's effects. So we're going to see a decrease in the levels of all of the anti-epileptic drugs, as well as of carbamazepine itself. With our CYP450 inhibitors, they're going to then inhibit the metabolism of carbamazepine and therefore lead to elevated levels with the increased chance for toxicity. Then our CYP450 substrates will go through induction of the metabolism of the substrates. So these are the agents that would normally go through CYP3A4, and then their metabolism is going to get induced. So these agents will have reduced effects in the presence of carbamazepine. Note here that oral contraception is one of the specific agents that will undergo an effect and lead to possible reduced effects of the oral contraceptive. So this is really important to talk to patients about if oral contraception is their form of birth control. So for carbamazepine's clinical pearls, really it's a compelling indication will be for bipolar disorder with rapid cycling. We see carbamazepine be particularly good in reducing the rapid cycling. Remember, carbamazepine, its pharmacokinetics, it does go through autoinduction. There are CYP3A4 interactions. Remember to do genetic testing required for patients of Asian descent for the HLA-B1502, and it is also pregnancy category D. Now, our next agent is Lamotrigine, and its brand name is Lamictal. Mechanism of action, again, we don't exactly know with its use for bipolar disorder. Lamotrigine is also an anti-epileptic drug, so we're going to see decrease in kind of excitatory neurotransmitters. So we see that it blocks voltage-sensitive sodium channels, can modulate or decrease both presynaptic aspartate and glutamate release, again decreasing the excitatory neurotransmitter. Anti-kindling properties, again, hoping to decrease rapid cycling and mixed states. And we really don't see this agent specifically have an effect on GABA, dopamine, acetylcholine, or norepinephrine. Lamotrigine is used for bipolar 1 disorder. It's also going to be seen for Lennox-Gastaut, for partial seizures, and primary generalized tonic-clonic seizures. Again, so this is an agent that we will see come again in neurology. In terms of our formulations, we have a tablet, a chewable, an oral dissolving tablet, an extended release, and a 24-hour release. So a lot of different formulations to pick from. Now, this is a big thing. So far, every agent we've talked about has been pregnancy category D. Lamotrigine is actually pregnancy category C. There is an increased risk of malformations following maternal lamotrigine use. It may be associated with higher doses. It's excreted in breast milk up to 50% of the maternal concentration. So again, there'll be caution with use, but we now have an agent that is pregnancy category C. So risk versus benefit isn't tilted, it's more neutral here. Lamotrigine's pharmacokinetics, it does get rapidly and completely absorbed. It's a little less protein bound compared to carbamazepine and valproic acid. It will be metabolized by glucuronidation. The half-life will be 24 hours if there's no drug interactions. About half of that if it's given with an enzyme inducer, and it'll be more than double that if it's given with an enzyme inhibitor. So the black box warning for lamotrigine is also for severe and potentially life-threatening skin rashes. So I will have you guys know the dosing for lamotrigine, and it requires a slow titration. Again, the black box warning is for severe and potentially life-threatening skin rashes. This is necessitating a slow titration. So, this slide, the dosing, very important. I want you guys to be very familiar with what the dosing is for monotherapy with an enzyme inhibitor, specifically with valproate, and then with an enzyme inducer, such as carbamazepine. So for monotherapy, weeks 1 to 2, 25 milligrams daily, weeks 3 to 4, 50 milligrams daily, weeks 5 to 6, increase by 50 milligrams per day about every 1 to 2 weeks, target dose being 200 milligrams daily. With valproate, it'll be 25 milligrams every other day, then 25 milligrams every day, increasing by 25 to 50 every 1 to 2 weeks with a target dose of 100. Now with our enzyme inducer, it's going to be double what the normal starting dose would be. So these aren't hard numbers to remember, but it's very important. And there are specific, if you look in Lexicomp, it will give you these specific dosing criteria. So with carbamazepine, we're going to start at 50 milligrams per day, then move to 100 milligrams per day, ideally in 2 divided doses, increase by 100 per day every 1 to 2 weeks, to a target dose of then 200 milligrams twice a day. The reason for the slow titration is due to the black box warning, the severe and life-threatening rashes. So, if a patient has not taken lamotrigine for more than 3 to 5 half-lives, which is about 3 to 5 days, we have to restart that initial titration. So again, if a patient misses 3 days of their lamotrigine, we're then going to need to restart the titration. So the drug-drug interactions, so the big one, the one that we have specific recommendations for dosing, the increase in lamotrigine levels will be in the presence of valproic acid. We're going to see decreases in lamotrigine levels with our phenytoin, phenobarb, and carbamazepine, which are all inducers, as well as oral contraceptives. So remember, carbamazepine decreases the effectiveness of oral contraceptives, whereas in this case, oral contraceptives decrease lamotrigine. Lamotrigine adverse effects, so this is also not an all-inclusive list, but note here, we have nausea, dizziness, headache, sedation, and a benign rash, so not a severe life-threatening rash. So much less side effects, and don't these seem a bit more tolerable? Ding, ding, ding. Yes. So lamotrigine, so it's actually first line for bipolar depression. So lamotrigine, if you remember back to the graph near the start of the presentation, in the presentation part 1, there's a graph talking about the different mood stabilizers. Lamotrigine really only covers depression. So it's first line for bipolar depression. It's not effective for mania. Now it's not going to cause mania, but if a patient is in acute mania, it's not going to be a good treatment for them. Remember, the black box warning is for severe and potentially life-threatening rashes, and we're going to need to do a slow titration. Slow titration. Compared to our other agents so far, we generally see this one being well tolerated. It's a bit safer in pregnancy with a pregnancy category C. So now we're going to very briefly talk about our antipsychotics. So again, thinking back to the graph, our antipsychotics in general will treat mania. Some of them are going to be particularly good for bipolar depression. So, in summary, in general, all typical and atypical antipsychotics can be used to treat mania. All atypical antipsychotics can be used for maintenance phase. We can sometimes see the typical antipsychotics be used as well, with haloperidol just being our most commonly used agent. However, not all antipsychotics are effective for bipolar depression. We have 3 specific atypical antipsychotics that will work on bipolar depression. We have lurasidone, brand name is Latuda, olanzapine plus a fluoxetine combination called Symbyax, and then we have quetiapine or Seroquel. So the FDA approved indications, the key that I want you guys to definitely know is the FDA approved bipolar depression agents. So again, Symbyax, Seroquel, and Latuda. So Symbyax being olanzapine, fluoxetine, Seroquel being quetiapine, and Latuda being lurasidone. These 3 are going to both help with our mania, as well as be specifically good for bipolar depression. So of the agents we've talked about, Lamotrigine, lithium, olanzapine fluoxetine, lurasidone, and quetiapine are going to be agents that will work on bipolar depression. Okay? So that concludes our last part of the bipolar lecture. So please do email me with any questions regarding this material, and we will get to class on Monday and do some application exercises with the new agents that we've talked about.